Dear participants, dear experts, I would like to welcome everybody to our webinar. It's a great honor again and great pleasure to host this conference today. Let me introduce our fantastic panel. Dr. Andrii Ruban, Center of Clinical Ophthalmology, Kyiv, Ukraine. We are waiting for Lukan Mishev. He's from Sofia, Bulgaria, Focus Eye Center. Dr. Professor Ahmed Sallam, Professor of Uveitis and Retina at the University of Arkansas for Medical Science, USA. We are happy that you join us. Dr. Vitaliy Belkin, City Clinical Hospital named after Botkin, Moscow, Russia. Professor Hussain Ahmad Khaqan, Professor of Ophthalmology, Lahore General Hospital, Lahore, Pakistan. And my name is Tatyana Avanesova. I work in Central Clinical Hospital, Moscow, Russia, and I will be a moderator and will show my cases. The webinar is organized jointly with DORC company, and we are lucky to have you here with us. Our today's topic is management of endophthalmitis, and now we have 55 participants, and we are waiting more. Before we start talk about endophthalmitis, we ask our audience to take a survey and answer the questions, and our panelists also can answer it. It's interesting to know your way of treatment. Can you show the poll, William? Please press your right answer, your answer. First, what are your tactics for acute postoperative endophthalmitis? Vitro step plus intravitreal antibiotics, then wait 24-48 hours. If no response, vitrectomy and with or without intravitreal antibiotics, or vitrectomy immediately with sampling and intravitreal antibiotics. Second question, visual acuity is in case of acute postoperative endophthalmitis the main criterion for vitrectomy? Third, optimal amount of vitreous removal in vitrectomy for acute postoperative endophthalmitis. Choose the right answer, your answer. Fourth, optimal type of tamponade during vitrectomy for acute postoperative endophthalmitis in absence of retinal tears. Saline, air, gas, and silicone oil. Do you think the use of systemic antibiotics is advisable for endophthalmitis? What intravitreal antibiotics do you use as the first-line treatment for acute postoperative endophthalmitis? I think we need to wait some time because we have now 74 participants. Maybe 1 minute. Lukan, hello. We are glad to see you with us.
Hello, everybody. Good evening.
Hi, Lukan.
Hi, Ahmed.
Can we see the results, Julia? Or need some time? Can you see it, these outcomes?
Yeah.
Okay, first question. More participants prefers to wait to put antibiotics and then wait. Don't follow recommendation by EVAS and do vitrectomy at first if the only light perception. Prefer subtotal vitrectomy with removal of the posterior hyaloid and almost equal percent between tamponade saline and silicone oil. And administrate systemic antibiotics. And sixth question about first line of antibiotics, vancomycin and cefazidime. Thank you so much. And we start our meeting with first speaker, Hussain Ahmad Khaqan, please.
Thank you, Tatyana. So I will share my part of presentation. Hope you can see my presentation, yes?
Yes, really.
So we are talking about endophthalmitis. So my role of today's presentation will be about post-operative acute endophthalmitis, and in all cases that I am going to show is about the post-cataract surgery. So we are talking about the post-cataract surgery endophthalmitis. So first thing is that acute post-operative endophthalmitis has a management and challenges. Management is not as much difficult as the challenges are. I will go on and I will explain why it's like this. Challenges we have basically patient's perspective and surgeon's perspective. What's patient's perspective? Patients had the high hopes for cataract surgery. He went for cataract surgery and ended up in endophthalmitis. So the hopes are very derailed now. So he had high hopes and he ended up in endophthalmitis. That's obviously a nightmare for cataract surgeon and obviously not a good thing for obviously retinal surgeon to deal with. And most of these cases are from referred centers from the cataract surgeon, anterior segment surgeon. Obviously, where the both facilities are, they are not referred, then they are obviously managed immediately. And most of the cataract surgeon, they usually refer these cases after the initial management. So these are the challenges regarding the patient perspective. The surgeon has a lot more challenges. First, he presented with a patient with have a painful, inflamed, infected eye with the corneal edema, hypopion, exudative membranes, posterior synechitis, small pupil, a lot of things that can happen in endophthalmitis, debris on anterior surface of lens, etc. And how it is more challenging for retinal surgeon. All this ends up in poor visualization of vitreous and retina that make the surgery difficult. Difficult in not in sense of technical and basic things, difficult in sense of visualization. When you don't visualize the things, it's very difficult to perform the surgery, and it more in sense in for the retinal surgery. And the second thing is the thought of the surgeon that the patient has had high hopes and he ended up in endophthalmitis. He had already surgery and now I am the last one who is doing surgery. So a lot of different thoughts in the mind of the retinal surgeon because he could be the last hope for him salvage the vein or the globe. So these are the few things that makes the surgery more challenging in terms of circumstances rather the surgical procedure. So I will show you the few cases from less complicated to the more, but these are all the cases of mostly cataract after post-cataract surgery. So this is the case as you can see, wound is prolapsed, iris is prolapsed through the wound and wound is gaped after phacosurgery, lot of debris pass in the anterior chamber with the Simcoe cannulas. I am going to wash these debris and here you can see. Here you can see the cavity is full of debris. View is not very much clear, but I am staying in the mid-vitreous cavity to take the debris and pass with the cutter, not being a heroic. Don't try to be the very heroic in this scenario. To go near the retina in the beginning, I'm just doing the core vitrectomy. Then as I get more clean and clean, so then I go near the retina and try to clean the retina as much I can. Thing here is that if you do lot of heroic work, you may end up in disaster. And here in the surgery, it was not much debris, and I ended up with a nice view of the retina. I closed the case with the air fluid oil exchange, and retina is not in bad condition. So I hope that it will end up in good visual acuity in post-operatively. I am injecting 5,000, sorry, 5,000 centistock silicone oil at the end, and these are the post-operative images. You can see retina is healthy, it's flat, it has a good texture, and hopefully the patient would have a good visual acuity in these patients. So this was my first case, and now I'm sharing my second case. This is a case again after post-cataract surgery. Patient had went for the phaco surgery and ended up in this situation. Lot of pus and debris. It's a relatively fresh case, acute stages, and removing the pus from the anterior chamber. You can see the difficulty here is small pupil, corneal edema, and it's the visualization. In this case, there's a debris is much more, pus is much more. So I am doing the core vitrectomy, then going near the retina, and you can see lot of debris is like a clotted exudation over the retina. So I am just using the little bit of vacuum to remove this debris. I don't use mostly the vacuum of the aspiration of the cutter. Rather, I use the back flush needle to just disperse the exudation from the retinal surface and bring it into the mid-vitreous cavity, as you can see over here. And then you can easily aspirate these debris and these exudation with the cutter. The logic of here is that when you do with the high vacuum, you aspirate these membranes from the retina, you may end up with the retinal tear and you may have the bleeding, and this surgery may end up in a disaster and you will end up in a massive bleeding. At the end here, you can see I can barely see the disc. Retina is flat, it's not detached, and view is not clear because during surgery you get the corneal edema and you get the edema preoperatively. There is a small ooze from the optic disc pit, and I close this case with the air fluid oil exchange. Here you can see the post-operative fundus images of the patient, and eyes retina is quite normal. And here are the different images of different portions: superior retina, inferior retina, and the posterior pole. Now we come to our third case. This has a massive exudation in the anterior chamber. Here you can see I cannot pull these exudation with the Simcoe cannula. So I have to use the end grasping forceps. As I remove the membrane, there is a more passes coming from the vitreous. And I have to cut the posterior capsule. Lot of debris on the posterior surface of the lens. Visualization is compromised because of the pupil. Lot of debris on the lens, lot of corneal edema, and lot of other things. So I am remaining in the mid-vitreous cavity and trying to clean as much as possible, but with every second, with every minute, I am going interior to posterior towards the retina to visualize the optic disc. So as I have the visualization of the optic disc, then I can do more vitrectomy, and now you can see I am going the peripheral retina and removing the debris and pus from the peripheral retina. These videos doesn't have a good quality because we can't have a good quality in corneal edema in some alts in patient having small pupil and debris on the pseudophakic lens. In all these cases, I'm showing you I didn't remove the lens, rather didn't remove the bag of the capsule. So to keep it inside, I tried to salvage the globe and salvage the vein. Now I am removing the peripheral vitreous in these cases. When you have a good visualization, you can go beyond You can remove as much vitreous as you can, but when the visualization is compromised, I think less is more. But rather than traumatize this retina that is already traumatized, it will be very dangerous for the future vision of the patient. And at the end here, you can see the similar approach I am doing for next case. Air fluid oil exchange is done in these cases, and that's the end of the surgery in these cases. Now I am showing you my last case. This patient has a recent phacoemulsification surgery. Here you can see the cornea is not in good condition and debris and pass into the anterior chamber. And you can see the visualization is not as clear as not much debris like previous case, but in this case, the cornea is not much healthy. So here I am doing the core vitrectomy, then I will go for peripheral vitrectomy. I am not very much anxious about doing the PVD and removing all the debris from the retina because it's not the basic objective. Because if while trying to remove all the debris, you may create the micro punctures, and these micro punctures may end up in the formation of large retinal breaks that may end up into the retinal detachment in post-operative periods. And as we know, these retina are all very fragile and they have a tendency of redetachment in post-operative period due to the entry site break, and there are a lot of other mechanisms. So my technique is same. So I finish the core vitrectomy, do the peripheral vitrectomy as much view as possible, and close the wounds with the vehicular sutures. So these are my few cases that I wanted to share in my presentation. Why I named it less is more. Longer the surgery, more the post-operative patient. So do the surgery in not much longer period. Don't do the heroic attempts to salvage everything. You can't salvage everything in these acute post-operative endophthalmitis eyes. Clean as much it's safe to salvage the vision. 90% is better than 100% disaster. Keep it in mind. Not getting for 100%, you may end up in 100% disaster in this eyes. Why I named these vitrectomies one-way vitrectomy, because priority of patient. So, and second, it wouldn't get more chance to redo. So do it with what's possible, playing it safe, because you wouldn't have much more chances to salvage these eyes. You are the end stage surgeon that can salvage the globe or salvage the vision. If you wouldn't do as much as possible, rather playing in safe side, it will end up in poor vision, or rather you wouldn't be able to salvage the globe. Do whatever you want. I prefer to use the laser endotamponade of silicon. I'll use the infusion with the antibiotic, suture the sclerostomies, and if anything else you can do to salvage the vision and globe. Thank you so much for kind attention. If we had question, we can discuss it in any stage. Thank you so much.
Thank you. Thank you. Wonderful talk. Hussain, can you stop your sharing?
Yes, please. Yes.
What antibiotics do you use and how?
I use
in saline or?
Yes, in BSS. Yes.
During the
vancomycin.
Only vancomycin?
Ceftazidime and vancomycin both.
And after that, systemically infusion?
Systemically, I give for 1 week ciprofloxacin, oral or injectable, and non-steroid and anti-inflammatory drugs only.
What time, what period of silicone tamponade do you prefer, or what?
I prefer silicone oil, 1000 centistokes, and I usually remove it in 3rd or 4th month, not for long time.
Thank you. Do you have some questions, dear panelists?
I have one comment, if I may. By the manufacturer, the ceftazidime and every other antibiotic should be diluted only in natrium chloratum or distilled water. So BSS is not the best way to use it. when we use, at least me, when I use antibiotics in infusion line, I always use saline.
Okay, good.
We have a question in chat. How do you decide on the types of tamponade you would use?
So, Tatyana, for me, I have no choice. I usually do only silicone oil tamponade in these eyes that I have shown you. These are nightmare eyes, and you cannot take any risk for these eyes. You saw the severity of disease in these eyes. Yes, in other eyes where you have a post-injection mild endophthalmitis with few debris patches in the vitreous, you can use any endotamponade, whatever you would like to prefer. But in these eyes, I need a clear media on next day to see the retina and vitreous cavity. That's my priority. And my patient that is already in trouble, he just want to see a little bit of world next day, rather than have a black bubble moving in front of the eye. So with the silicone oil, if you can salvage the eye, you can prevent the inflammation, you can prevent the infection, and your patient can see next day. It's a big hope for him in the future. And third, so as a surgeon, you can see the retina, third thing. And fourth, in these eyes, my preference is only silicone oil. 1000 silicone oil doesn't harm these eyes for shorter period of tamponade, and my preference is mostly the silicone oil.
Thank you, Hussain. What is your indications for tamponade, Dr. Sallam? Can you?
Thank you so much, Tatyana. So really my indications of tamponade, if there are any retinal tears or detachment. Otherwise, I would leave the eye BSS filled or air filled, and I would use air just for the hypotony. But silicone oil does have a bacteriostatic effect, but the main thing really is the treatment, in my mind, is the treatment of with intravitreal injection. So I don't use oil. And even if I have a tear in a clean area, I would still use gas. Oil, if there's like tears or multiple tears and there's persistent traction, everything is very mucky, that's where I would use oil.
And if you leave a lot of vitreous, you have bad visualization. You also put no silicone oil.
Yeah, no. So usually the majority of them, I don't shave. If the hyaloids is really easy to separate, I would separate it cautiously, but if not, then I would leave alone. So I choose like depending on the visualization choice on the pole, I would not shave the vitreous base, and I just want to end up with like debulking and no breaks.
Do you have in your practice cases that the inflammation was not go out, so you need to reoperation or to put antibiotics again?
Yeah, so interestingly, I mean, the idea of like peripheral shaving is to try to debulk more, decrease the infection load, and also try to avoid hypotony happening because of cyclitic membranes. But really, I've seen very, very few cases, if any, especially with the post-procedure. I've seen more like, for example, with viral retinitis, more cyclitic membranes, but usually they resolve so well. So you come to reoperate for that, for vitreous opacity again, or no, not really?
So if we operate on time, in almost all cases, we will have good result. It depends on amount of vitrectomy plus antibiotics.
I mean, I think you could argue both ways. I think, and I think I may talk about that in my presentation. I feel really, yes, intervention has to happen in time, but what's this intervention? I think that's debatable.
Okay, yes, Lukan.
And I'm also a fan of silicone, actually, because of the bacteriostatic effect. There is no bacteria which can grow in the silicone. And in the initial stage where we need to save this eye, as Khaqan said, we need to have something to rely on. We don't know if this is, sorry, this is my dog barking, sorry. you don't know if this is a bacteria or fungus. So until the antibiogram is ready, I prefer to have a safe tamponade and eye that is more or less in a steady state. Because when you have a saline or gas, you don't know what happened inside the eye.
Okay. Yes, please, Hussain.
And the thing here is that it depends on the severity of cases. Okay. The
Of
thing
course,
is,
yeah.
timing is very important. But the most important is even you have a next day, you are going, for example, you have removed the bandage of the cataract surgery patient and you get an endophthalmitis and you are going in evening for his vitrectomy or her vitrectomy. Timing is good. Okay, you are operating in 10 or 8 hours as immediate, but the issue is the severity. The severity takes much role rather than the timing, because if it is severe enough, it will slough your retina, it will slough off your cornea. Even your good timing, you wouldn't salvage the retina, because retina, if it is sloughed off, what your vitrectomy or anything will do. Second, yes, there are different opinions regarding tamponade, but believe me, I have tried many, and the continent where I am living, and we are doing surgery, bulk surgery in cataract surgery, 100 surgeries per day. We encounter such nightmares sometimes, and I know the behavior of these endophthalmitis, and many of eyes I left sometimes in BSS or in gas. But believe me, those eyes next day talk with me that what you have done with us. Believe me. And I sooner or later I get most of these eyes retinal detachment, even if they didn't have break operatively. From where this detachment gets, everyone knows these are very fragile sloughed retinas, and any time they can detach. So different situations, different conditions, but you have to decide the best way of for your patient. Thank you.
Thank you, Hussain. We have question about your third case, about outcome and visual acuity. How was it?
So in third case, where I used the end grasping forceps, this patient ended up with the counting finger VN, not much. Because this case has an acute infection, not settling one. This patient didn't have any injection preoperatively. We gave the injection and prepared for the next day. It has the severity of disease much more. So see, these cases have a pale disc. When you go inside, you get the pale disc. The pale disc means that either the high intraocular pressure after the injection by the anterior segment surgeon, either the inflammation and debris and high intraocular pressure has already damaged the VN. So the thing here is that if you get a healthy optic disc, operatively, the VN is good. In third case, you saw it's a relatively pale disc rather than to comparing the first two cases. Those were very, very, you can see in severity, but their disc was healthy. But in third and fourth case, disc was not healthy, although they were surgically not very much difficult. So it depends on the optic disc most of the time. Macula is mostly healthy until unless it's very late for surgery.
Thank you. We have one question about sampling, but our next speaker will tell us about how can we make this sample. Please, Ahmed, can you share your presentation?
Sure.
You're the next.
Shall I start, Tatyana? Yep.
Yes.
Okay, well, thank you so much for the kind invitation. I'm so delighted to be here with you. I will just talk about vitreous sampling. So before going into that, in conclusion, that's what I tend to do. So I tend with post-procedure and post-operative endophthalmitis, regardless of the vision, even if it's a light perception, I tap and inject within 1 hour of the diagnosis. This is what I tend to do. Sometimes I do not do the dexamethasone. Mostly I do.
We don't see your video.
You don't see my slides?
Only first one. Yeah. Yes.
Can you see my slides?
It's okay. Yes, yes, it's okay. In
It's all right?
conclusion, yes.
Yeah, okay. And then I review these patients, and the main decision really, unless they grow strapped on the gram stain or culture early, the main decision is within about 36 hours. And if it's better, if it's not better, then we do vitrectomy and repeat inject. If it's better, then we just watch. And this eye, is, in my mind, is sterile, and only what needs is steroids, and just wait. Maybe these patients later on, they will need vitrectomy for opacity or for whatever, but this eye is usually sterile if it's better. So that's what I tend to do.
I'm sorry, just one
Yeah.
slide with one expression in conclusion without video.
Yes,
or
there's
it's
no
okay.
video yet.
Emma, take
Is that okay?
It's your last slide. Emma, start from
Can you
the
see
first
that slide?
It's last slide, yes.
Just
Start from
words in conclusion.
Oh, I don't know why it's not working. Maybe let me, I'm sorry, I apologize. Let me share the screen instead of the program.
Yeah.
Maybe that would help. Yeah, let me, okay, I'll share the screen better. Can you see the screen?
Yes. No.
Okay, all right.
Yes. Everything is perfect.
So before I show you the sampling, I just want to remind you of something very, very quickly. At the endophthalmitis vitrectomy study, we all know the finding that if there's a light perception, there's a separation in visual acuity, with eyes that had vitrectomy did better. However, if you look at the second graph, if it's better than light perception, there was no difference. There's something very important as well to take from the endophthalmitis vitrectomy study. This is so important in our understanding that 7% in each group had a re-injection rate, which means that 90+ of the eyes became sterile after one injection of antibiotics plus or minus vitrectomy. And that's really very important in our understanding what to do, in my mind. This is also very important as well, that, you know, as time goes and you're setting up for a vitrectomy, the organism is multiplying, and staph epidermidis, the most benign, actually multiplies in 20 minutes. So in an hour, it's like 5 times multiplication. That's one thing about the oil as well. If you look at this graph, if you look at where it says time more than MIC, that's the minimum inhibitory concentration. If you go 4 times or less, that's a bacteriostatic medicine. If you go more, then you become bactericidal. If you go 10 times more, then you become, I'm sorry for that. If you go 10 times more, then you become Cmax, which is really a maximum medication efficiency. Vancomycin and ceftazidime that we put in the eye is 50 to 200 times more. So it's actually super MIC. So that's why using silicone oil just because it's bacteriostatic is not really of a very significant importance. Again, we can argue about that a lot, but it's just, these are good things to remember, that the dose we're using, they're called super MIC. It penetrates into biofilms, and that's very hard. And that's the results of the poll here that Tatyana very nicely have done. And really, I think it shows what we found in newer study from the European Vitreoretinal Society, that there's more uptake of vitrectomy, and that's what we found in the first study. But when we looked really at, okay, what's the vision between patients who had vitrectomy or no vitrectomy in post-procedure and post-operative endophthalmitis, vitrectomy did not fare better. And really, I think my interpretation of this is, yes, vision, people are not counting on the vision as the main starting point, but most of the people, or at least, you know, more of the people are actually treating with vitreous tap and inject early on, then we can talk about the vitrectomy. And that's what I tend to do. Let me show you 2 things here about the sampling. this is how I do the vitreous tap in clinic. I use one trocar. I think it's easier for the patient. So I usually give them anesthetic, subconjunctival anesthetic, and wait for 5 or 6 minutes. Then I put one trocar, and then I take the tap from the trocar, and then I inject through the trocar. I just find it easier, and we don't stab the eyes many times. And then the injection follows. And then we take the tap off. This is the vitreous biopsy, and there are different techniques of doing vitreous biopsy. And the classic technique is doing a tri-tap with the vitrectomy where the infusion is off. But in one occasion, I actually, when the eye collapsed, I went into the lens, and my fellow, and this what happened like maybe 6-7 years ago, and my fellow in a case last week did the same. If you are trying to take a big sample, the eye would collapse and you may go into the lens, especially if you're dealing with a phakic patient. So really what I love to do is to get a big sample is do vitreous biopsy under air, and that's the technique. The line has been primed under air, and I'll show you now how to do this. We check that it's inside the eye, and then the vitrectomy starts. And if you imagine what's going to be happening now, as you cut, the air comes and fill in the eye, and you can get really up to 2 mil or even 2.5 to 3 mil with this technique. And then you can divide the samples, especially if you're not reassuring if you're dealing with endophthalmitis or, for example, lymphoma. And that's what we tend to do with the vitreous biopsy now. We do it under air. So here, in this case, really was a patient with suspected lymphoma. And then you switch to BSS and reconnect the syringes. Let me show you how this happens from outside. So you get the infusion to air to dry the line. Some machines you can actually miss the priming, but with Constellation, the machine like goes crazy. You also dry the cutter, and that's what I tend to do as well with air. And you find that there's fluid coming from the cutter. Then you reconnect the infusion and it's on air. And you have the syringes ready. And now this is what's happening now. We aspirate. And we usually send for bacterial culture, viral PCR. That's if the diagnosis is unknown. If you're dealing with endophthalmitis, you send only bacterial culture, and for lymphoma. And then here we reconnect the vacuum line, and that's how it happens. And that's really how it looks like. Thank you so much. And I'll send the links for the audience. I'll send the links for these 2 videos, the trocar and the vitreous biopsy under air, in the chat group for the audience.
Thank you so much.
Thank you.
Very particular case and interesting presentation, and thank you for sharing your experience. Yes, we are waiting for your video, and we have some questions from audience. Can you please close your screen?
Yes, sorry, stop share. Yeah. Sorry, I finished. I will send the link for these 2 videos I showed.
Thank you. Thank you. Do you use the same technique for fungal endophthalmitis if you suspect it? The same?
So, yeah, the same. So you mean for the biopsy or?
Yes, tap. And after
yeah, so every time I do a biopsy, I do it this way. Unless I cannot see the...
Not in
the
operating theater.
In the office, yeah, I do the trocar this way. I think it's nicer. But there was a study that actually showed no difference for patients. But I find it nicer. It's just easier to do. Yes.
Thank you. We just have commented great work in our chat. Do you have some questions? Yes, please, Andrii.
Ahmed, thank you so much for your beautiful presentation. And Casey, could you suggest how often do you use results of gram stain? Is it useful? How often do you use in your practical results of gram stain? How it's quickly, how it's useful in your practice?
In my practice, the only thing really is just gives you an idea, but you need to know really about the contamination. And I think the main thing I'm looking for is this strep or gram negative, especially if the endophthalmitis is coming early on, because that will tell me that this is a very aggressive endophthalmitis. So I just want to make sure it's not strep and not gram negative. That's the main thing really I look for in the gram stain.
Thank you.
Thank you. Dr. Ruban, you are the next speaker. Can you show us your presentation?
Do you see my screen? Yeah. Dear colleagues, it's a great honor for me to invite in such a beautiful meeting and a great team. And thank you, Tatyana. Thank you, Dork. I would like to present two my cases. First, it's a 52-year-old man who was referred to our department with diagnosis of endophthalmitis 3 days after intraocular foreign body caused perforating open globe injury. Only corneal sutures are applied at local hospital and topical antibiotics appointed. He suffered from visual loss to light perception, increased ocular pain with anterior chamber and vitreous reaction eupopion, fibrin formation, iris and lens perforation, traumatic cataracts, and vitreous inflammation. We all know that approximately every fourth case of all endophthalmitis is traumatic. After open globe injury, chance of development of endophthalmitis is about 7%. Injuries, including intraocular foreign body, have higher rates of endophthalmitis. And we also know the main risk factors, which include dirty wound, lens capsule, rupture, age more than 50 years, delayed presentation, or more than 24 hours after injuries. Bacillus and Staphylococcus species are more common in penetrating trauma with intraocular foreign body. And we also know that post-traumatic endophthalmitis has maybe worse visual prognosis, except fungal, than other categories. What we should do in such cases, it's not so easy and not so clear. Application of EVRS may not be appropriate due to different organism, and some authors advocate therapeutic vitrectomy in all cases of traumatic endophthalmitis. Others suggest performing vitrectomy only if patients don't respond after 48 hours and rapidly deteriorate in the first 24 hours following intravitreal antibiotics. Although the EVRS results showed no benefits of vitrectomy over TAP and intravitreal antibiotics, recent trends thanks by Ferenc Kuhn and Gianpaolo Gini towards performing early and more complete vitrectomy without waiting for vision to drop down to light perception rate. Early vitrectomy in a less damaged eye may be another advantage for the vitrectomy. And regardless of the presented visual acuity, the media clear faster with vitrectomy than with TAP and biopsy. Vitrectomy in such cases is not so easy procedure and not so with good results. We talked about that. Even 30% of eyes on EVS study requires additional surgery, either for surgical complication or progressive intraocular inflammation. The mean incidence of retinal detachment after 20-gauge vitrectomy about 11%. And the most common cause of visual loss was attributed to epiretinal membrane formation, macular edema, and macular ischemia. And the strongest predictor of poor visual outcome was light perception, only vision. Technically, vitrectomy, we all know, should be performed very, very delicate, and care must be taken not to induce iatrogenic traction. It's with a low possible suction and high vacuum rate and never pulls the cut away from the retina. What about prophylaxis after penetrating trauma? Clinical evidence not established, and some authors advocate intravitreal antibiotics administration in all cases of penetrating trauma. Other recommended administration in the presence of some risk factors. Biggest part use systemic antibiotics, intravenous cefazolin, for example, followed by agent followed by fluoroquinolone fourth generation as a gatifloxacin or moxifloxacin for 7 days. Our protocol in such cases, it was vitrectomy, prompt vitrectomy as soon as possible with geta sampling and intravitreal antibiotics. Before surgery, patient was appointed with systemic antibiotics, cefepime and Lomade. A vitreous sample of 0.5 millimeter is first obtained without infusion using gentle manual aspiration into a syringe. It was negative, unfortunately. Immediately after scleral 1 closure, intravitreal antibiotics, vancomycin and ceftazidime were injected intravitreally. We performed phaco-vitrectomy 25 gauge and lens removal with lens implantation. After central vitrectomy, we are trying to remove posterior hyaloid as much as possible, of course, with much safety. Unfortunately, I have got iatrogenic retinal tears. I haven't bevel tip vitrectomy at that time. But it's very important to remove all traction on the tears hole. It's very important to predict retinal detachment. Fortunately, retina not so damaged without severe retinal toxicity signs. It was place of exit point of intraocular foreign body, extrafoveal. Peripheral vitrectomy, but very, very delicate because it's very difficult to visualize peripheral retina. Laser, I inject only air and intravitreal antibiotics. Questions for experts. I have some questions and many of them already was answered, but I repeated them. Maybe more argue question about eol implantation during vitrectomy and how maximally remove posterior hyaloid. In my experience, in my way, it was we show that, and I can obtain and get vision 0.1 at 3 months after surgery, and retina was attached. My second case, it's a woman, 65 years old, previously underwent vitrectomy 27 gauge for epiretinal membrane. He had vision 0.5, and third day post-op, he suffered with a visual loss to light perception, increased ocular pain, and with anterior chamber and vitreous reaction, hypopin, fibrin formation, and vitreous opacities. We appointed topical and systemic antibiotics. Systemical was moxifloxacin, intravenous, followed by tablets, anti-inflammatory drugs, and samples from anterior and posterior chamber. But we did not inject intravitreal antibiotics, but use 0.025% povidone in irrigation solution. Why povidone? Because it's exhibit diverse microbiological action against multi-drugs resistant bacteria, Candida virus, and Acanthamoeba. Povidone has additional advantage because it's absent of drug resistance and rapid bacterial effect and low cost. In addition, its safe concentration and toxicity for intraocular tissue have been studied in details. We use techniques or protocol described by Hiroyuki Nakashizuka is according which this solution was prepared within 15 minutes. We using this solution within 15 minutes after preparation. First of all, clean anterior chamber. Technically, vitrectomy in vitrectomized eye is not so difficult, and it's maybe more looks like lavage. We detect intraretinal hemorrhage. Also performed air fluid exchange, and operation was completed. At 3 months, visual improved dramatically to 0.8, and patient had a very quiet eye. The first report case of endophthalmitis following 25-gauge vitrectomy was published in 2005 by Taylor and Ewald. And in their cases, the vitreous sample was also negative. And after intravitreal and oral antibiotics, vision increased to 2020. The incidence of post-vitrectomy endophthalmitis in the initial period was reported higher than after 20-gauge vitrectomy, and proposed explanation to this was non-sutured wound and the frequency of gapotomy. As shown also by Tominaga et al., transconjunctival microincision vitrectomy has a risk of bacterial contamination about 11 times higher than that in 20-gauge vitrectomy. But with advance of surgical techniques, instrumentation, and our learning curve in understandable one construction, multiple reports support that the incidence of post-vitrectomy endophthalmitis does not depend on the gauge, and about approximately 0.05. There are some potential predisposing factors for endophthalmitis after vitrectomy sutureless. It's leaking sclerotomy. So we know that it takes about 2 weeks for complete 25-gauge wound closure. It's early postoperative hypotony, in patient-induced wound distortion, such as with the eye rubbing, the presence of a vitreous wick in the sclerotomy site, non-use of, for example, subconjunctival antibiotics as the conclusion of the vitrectomy, but it's a very questionable topic. Increasing use of intraoperative intravitreal adjuvants such as triamcinolone, acetonide, less complete vitrectomy, and using BSS and BSS-filled vitreous cavities as a conclusion of the surgery. We should very strictly use some regime for preventing endogenous bacterial endophthalmitis, as according to microsurgical safety task force, which include the preoperative preparation, antiseptic preparation with povidone iodine, eyelashes completely out of surgical field, intraoperative is displacement of connective, very important angle scleral incision, and using some kind of tamponade. At the end of the surgery, we should minimize vitreous incarceration and cutting off of the vitreous wick. We should inspect wound and use suture if necessary, and wash out the connectiva with povidone iodide again. In postoperative period, recommended use antibiotics and patient instructions. According to postoperative using and administration antibiotic is not so clear topics. Postoperative antibiotics, for my opinion, better to use fourth generation because they're equally effective against gram-positive and gram-negative entirety. But subconjunctival antibiotics usage has greatly decreased last time. One of fresh publication, Austin Lagros, suggests that performing transconjunctival vitrectomy without prophylactic subconjunctival antibiotics did not lead to an increase in incidence of postoperative endophthalmitis. Endophthalmitis vitrectomy study did not enroll patients with post-vitrectomy endophthalmitis, and this results does not directly apply to these cases. Nevertheless, certain principle can be applied. Its main vitreous steps and inject is a quick and inexpensive and very, very technically used procedure, as we shown previously by Sallam. Prior to antibiotic injection, a vitreous cavity semen should be obtained for culture results. A negative microbiology report does not rule out endophthalmitis, and in case of DAB, one can repeat the sampling and treat with a broad spectrum intraocular antibiotic combination. Since there are no guidelines for post-vitrectomy endophthalmitis, initial treatment possible to begin with antibiotic is a widely acceptable first line of choice. But because of risk of retinal toxicity, the lowest published effective dose should be used, and the antibiotics diluted in the infusion line are not recommended because it's difficult to know exactly the common retinal dose. Even through endophthalmitis, vitrectomy study found no significant benefits. We have been using it because its concentration of intravitreal inject antibiotic can be rapidly decreased. I mean, a systemic antibiotic. We can be using as additional tools because we might, in our practice, uses both route of administration and intravitreal as well as systemic, and should be used to obtain effective dose of antibiotic. And some of our questions for experts is, for your opinion, do you think the use of systemic antibiotics is advisable for acute post-vitrectomy endophthalmitis? And does the use of systemic antibiotic reduce the information value of specimen obtained in the vitreous body? And do you think the use of intravitreal antibiotics must be mandatory for acute post-vitrectomy endophthalmitis? And do you think the subconjunctival antibiotics usage has greatly decreased the rate of post-vitrectomy endophthalmitis? It's my answer, and I would like to hear your approach. I think it's maybe the most important things which we should remember that dealing with endophthalmitis is, of course, early detection and prompt treatment. Thank you so much. Дякую.
Thank you so much, dear Andrii. It's not just presentation, it was actually a lecture for all of us. Thank you so much. Can we start with first case, and you can add me, but I remember very actual and interesting question about changing lens and making phaco. First, maybe could I ask Lukan, would you change the lens if you have a patient with endophthalmitis, phakic patient?
In fact, I will remove everything, the lens and the capsule and everything which is in the anterior segment, because especially if the lens is hydrophilic, it's already infused with whatever is in the eye. So I slightly disagree with implantation of the IOL in an eye with endophthalmitis.
If your patient is phakic, you would do lens removal without any implantation.
If my patient is phakic, it means that this endophthalmitis is not post-operative probably, or not post-cataract.
Yes, it was post-traumatic patient.
I will remove the lens, I will leave it aphakic. There are a lot of options for aphakic fixation of IOLs if this eye improves after the initial endophthalmitis vitrectomy.
Thank you. Vitaliy, what is your choice?
Hello, I think I'm sure with Lukan, because if we have traumatic eye with we must get out the phaco, the lens, and remove the lens, and leave the eye without the lens until the eye will get better. Then we can reimplantate the IOL, and that's the point, I think.
Thank you. I would leave the lens. What's your opinion, Dr. Sallam? Please mute.
About if the patient is phakic?
Yes,
So we're
if
dealing
the
with a
patient is
traumatic or endogenous endophthalmitis and the patient is phakic, right? Maybe that's the question. So I think if I can see well, I will leave the lens alone. I will not gonna remove the lens. If I cannot see well, then I will remove the lens. And in this scenario, I would not implant. And I will come back and implant. Question is, would I remove everything or leave capsule? It depends. I think if the eye doesn't look so bad, then usually what I do is I do a posterior capsulorhexis, and I would leave things like this, hoping that I will come back and put a lens in the bag later on. Of course, if it's all messy, then I will take all the capsule and everything out.
Thank you. Thank you, Dr. Khaqan.
Okay. In traumatic eye that Andrii Ruban showed in this eyes, so my preference will be, if it's a cataractous lens, then yes, I will remove it. And if it has a foreign body has gone through the through the crystalline lens, yes, then I will remove it. The question is that whether you will implant the secondary IOL, yes or no. In post-traumatic endophthalmitis, I wouldn't implant any intraocular lens at the time of the first surgery. And second question is whether you will leave the capsular bag in these cases. Yes, there are two options. If the severity of endophthalmitis is too much in post-traumatic endophthalmitis, then I would prefer to remove the bag also. But if the severity is not much, as Dr. Andrii Ruban showed, then I can leave the bag but wouldn't implant it. I will definitely do the posterior surgical capsulotomy and all the else thing, and depends on the other severity. But implant in the first go, I wouldn't prefer in post-traumatic endophthalmitis. Yes.
Thank you. What are these questions, Andrii, from first case about tamponade? Yes.
Andrii, nice presentation. It's very nice to see your first case. My understanding is that when you have endophthalmitis, you already know that retina is fragile. It's not like a normal retina, as in retinal detachment and even in diabetics. So I usually prefer not to use the cutter high aspiration to induce the PVD. And it's not very much important to induce the PVD in the start of the case. So you can wait, let the fluid churn in the cavity, and it may help with the time to have the posterior highlight detachment by itself. And even if it's not detaching in endophthalmitis, I think it's not very convenient to detach the posterior highlight and end up in creating the breaks. And you can even use the back flush to induce the posterior highlight. The second thing is that I totally agree with your plan in the first case, except intraocular lens implantation. Vitrectomy should be soon. It should have an endotamponade and obviously laser. Thank you.
Thank you.
Thank you. And second presentation question: do you think the use of systemic antibiotics is advisable for acute post-vitrectomy endophthalmitis? Can you show with your hand who think the same?
Systemic antibiotics.
Yes. Okay. I took photo with your questions. Does the use of systemic antibiotics reduce the information value of specimen obtained from the vitreous body and anterior chamber? Does the use of systemic antibiotics reduce the information about positive organism? Yes.
It depends. If
I don't
it's
know.
if the organism is sensitive to the antibiotic, otherwise not.
I think yes, but it's really is like slightly irrelevant because what happens? This patient comes in, right? Then you will do the tap and the injection, then put the patient on systemic antibiotics. So I think really, whatever, I mean, the systemic antibiotics may have an adjuvant role, but the main thing is in the intravitreal antibiotics. So I think the timing issue is not going to cause a problem with any sampling, if any. That's my thinking.
Thank you. Third question. Do you think the use of intravitreal antibiotics must be mandatory for acute post-vitrectomy endophthalmitis, not post-operative, not post-phaco post-vitrectomy? What's your opinion? Please,
In
Ahmed.
my view, 100%. I think that's the main line of treatment. I think whatever you say is just adjuvant, including the vitrectomy, really.
The same dosing as in post-phaco.
Yeah. So this is my view. I think the short answer is if the eye is BSS filled or air or gas filled, we do the same dose. If the eye is silicone oil filled, we do half the dose. That's my short answer. There's a very, very long answer. We can go through and look at the evidence, but that's my short answer. Half the dose only if silicone filled.
Just before putting silicone oil, half dose.
If the eye is going to be silicone filled, so if you like, if you put the silicone oil, then put the antibiotics at the end, or you put the antibiotics and then the silicone oil. I always advise the antibiotics at the very end when the infusion is out. Because as Andrea said very nicely, it's very difficult to know what you've done if the infusion is going on. And that's why really putting antibiotic on the infusion, in my mind, really is not very accurate. So everything out of the eye, then the antibiotic goes in.
Yes, but when you put the silicone, you're under air, I suppose. So what is the role of the infusion? When you have air, then you put silicone, and the normal logic is to put the antibiotic before injecting the silicone, I think.
You know, again, I think there's one of the things that we can argue about a lot, but I think that's what I do. I think you have a point. When air is there, maybe fine, there's no infusion, but I think antibiotic needs to go in with there's no infusion, so you know what's the concentration.
And you prefer vancomycin plus ceftazidime?
Me, yes, that's our usual vancomycin ceftazidime.
Do you have experience with BSS plus povidone iodine?
No, I don't have any experience, but I've seen the studies that Andrii referred to, and I think it's very plausible. I think it's a great idea. If I use it, I would use it as a bolus at the end as well, not on the infusion. And I think there's a Japanese study that did that and tested it. I think it's a great idea. Prophylactically, I don't use any subconjunctival injection. After any intraocular surgery I do, I put a drop of iodine at the end. On the
what concentration? 5%?
5%. 5%. That's what I do with every intraocular procedure I do.
Thank you. And last question: do you think the subconjunctival antibiotics usage has greatly decreased the rate of acute post-vitrectomy endophthalmitis? We know your answer. What about Hussain?
I don't use subconjunctival antibiotics in any surgery, in a vitrectomy, never.
Just drops, just
no.
Fluoxetine or...
It looks strange, but I just complete the vitrectomy. If I have to suture it, I suture the ports and just put the pad. No drops, no subconjunctival antibiotics, because it doesn't make any sense.
What about steroids?
Steroids, yes, in cataract surgery, I inject subconjunctival steroids, but it's very rare when I am doing in general anesthesia. But when I am doing phacosurgery in topical anesthesia, nothing, even not steroid drops.
Okay. Can we go ahead, Andrii? Do we have some questions?
I Tatyana, just very quickly, I want to congratulate Andrea about his case where the break was and he cleaned around it and put air tamponade. I think that's really a great management. I think the most important is clearing around the tear. Then if it's cleared around with tamponade, it would just close. So that was actually a fantastic case.
Thank you.
Thank you. We have some questions. Dear colleagues, what do you think about silicone or perfluorine tamponade after vitrectomy? Do you use this perchlor organic agent?
He meant perfluorocarbon, I think.
Yes, perfluorocarbon. Do you use it?
No.
Okay. Okay, let's
My
go.
question, can I have a question?
Yes, please.
So we have Ahmed, Lukan, Andrii, and Vitaliy, and you. So how many of you, after doing vitrectomy for endophthalmitis, and if you use silicone oil, you inject antibiotic injection after this?
You mean subconjunctiva or in
No, intravitreal. How many of you? Just raise the hand. How many of you?
Silicone and intravitreal antibiotics.
So, yes, you have done the vitrectomy for endophthalmitis, and you have given the endotamponade of silicone oil. You have sutured the ports, obviously, in 23 gauge, sclera is fragile, your ports are leaky, obviously. Now, how many of you will inject antibiotic in this eye?
I don't use.
I
No.
don't use, no.
No.
In endophthalmitis, right? It's an endophthalmitis case.
In endophthalmitis vitrectomy, you end up with the siliconized eye, and per operative, you have sutured the ports and you are finishing the case. Yes, before removing the speculum, would you like to inject ceftazidime or vancomycin in this eye? Yes or no? Or later, would you like to inject it?
maybe
What
later.
is the other option? So the treatment of endophthalmitis is intravitreal antibiotics. What's the other option if you not inject? I mean,
Because
I
of
would
silicone
inject,
oil has bacteriostatic effect. We
it's,
talk
you know,
about.
as I showed on this curve, we're talking like 4 or less minimum inhibitory concentration compared to 50 or 200 times minimal inhibitory concentration. So I think really you cannot compare, again, that's my view, you cannot compare the silicone oil to super MIC concentration. So I would definitely 100% inject in any endophthalmitis case antibiotics.
No, you will inject when you have finished your vitrectomy oil, yes?
Yes.
Yes, and I will inject half the dose.
Before removing the speculum, you will inject the antibiotics vancomycin and ceftazidime. Did I understand? Thank you.
Yes, and half the dose.
Okay, thank you.
Thank you. Vitaliy,
Yes.
please show us your first
Just a second.
extreme case.
Well, hello, dear colleagues. Just a second. First of all, I would like to thank Tatyana for the opportunity to take part in such useful and interesting webinar. So the case number 1. I would like to dwell on the history of this patient because he is very heavy and rare for us. It's 52 years old, male, denies chronic diseases. At October 20, he had a flu vaccine. Then at October 20, he had a pneumococcal vaccine. And then at November, he suffered SARS with a temperature of 14.5. All COVID tests were negative. And both eyes have visas with 100. But at November, vision on right eye decreased dramatically. Patients turned on to the emergency and diagnosed with the retinal occlusion. And then next day after, dramatically reduced vision on left eye. He was hospitalized with diagnosis endophthalmitis on both eyes, so unclear. And in that day, his both eyes was already praxis lucerta. And it's an emergency situation. We have on the next day we have left eye vitrectomy, tamponade silicone oil, and we have seen on the retinal surface white tissue detritus, retinitis with necrosis of the retina. On the next day, the right eye was exactly the same vitrectomy and the same picture on the retina. Then after 3 days, the patient develops community-acquired bilateral maxillary destructive pneumonia, septicemia, and he was transferred to the thoracic surgery department. Further, the liver lesion, and the patient entered intensive care with a clinic picture of sepsis. And he goes from us about for, as you see, 3 months. During the time spent in intensive care, corneal dystrophy develops with the transition to peroneal ulcer on the left side. So when he was returned at the March of 21, we have to do the vitreal cavity revision on the right eye with the phaco and oil changing, silicone oil remover, retinotomy, and silicone oil tamponade once again. Then we have on the left eye in April keratoplasty. That's because of the ulcer. And then he entered it's July. He entered for the phaco and oil vitreal cavity revision on the left eye. And this is of the left eye before the surgery was praection lucerta. So after removal of the major cataract and the silicone oil removal, we detect this retinal condition. We don't see it because of the major cataract. Retinal detachment cross severity and proliferation throughout retinal surface, as you can see. I tried to handle it with my one hand. But when I realized that I could not cope it with one hand, I put a chandelier and switch it to a bimanual technique, trying to separate and remove the retinal membranes as much as possible. As you can see, there's pretty heavy damage. That's the chandelier. Trying to separate them. And you can see that on the peripheral retina appeared unviable, and circular retinotomy was performed. And we have just pretty heavy structures. I don't know, maybe it's a retina with some kind of inflammation, or maybe it's just already so a little bit of vascular undercoagulation. Retinopexy. this situation is on the both eyes, exactly the same. This is perfluorocarbon, and we try to just to expand retina under perfluorocarbon as much as we can. When I'm changed to the air, I have found one more traction that goes from the choroida, not from retina. So I cut it, and it was strange too, because it's a really strange thing. Then we go on the silicone tamponade. As you can see, the retina is pretty bit slaughtered, and we go in the laser on the silicone oil. So post-operative results, the vision of the right eye after 4 months after the surgery on the silicone oil tamponade is 0.2, and the vision of the left eye and a week after surgery was 0.1. And what we have such a conclusion after crops. What conclusion we have after crops? It was Klebsiella pneumonia, very heavily damaged with the retina, and the patient who have 100% lost in 1 day or 2 days all of it. That's a pretty interesting and rare case, as I think.
Thank you so much. We think so. That extremely difficult case, and we know that endogenous, even bilateral case, endophthalmitis, metastatic endophthalmitis, almost always has not good results. So our congratulations that your patient can see 0.3 and 0.1. I think it's a success. Do you use special antibiotics for this Klebsiella? Can you tell us about this treatment?
Yes, we use moxifloxacin systematically, and we have vancomycin under the silicone oil. Yes, of course, only with antibiotics.
Thank you. Do you have comments, the panelists? I'm going to remove the silicone. Or what do you think? Maybe the silicone for a long time.
We think about it, but I think that we can remove silicone oil on the right eye because it's what's 4 months, and maybe we should get with the laser once again, remove silicone oil, and I don't know how can retina will be take off the place. Maybe.
Yes, please, Lukan.
Vitaliy, congratulations. This is a really interesting case, and it's something definitely which we need to look now after COVID situations. I think the both eyes are silicone for life, only you need to exchange it, but the success is magnificent. 0.1, 0.2, it's something that if you are able to maintain as much as you can, it will be with silicone, because when you remove the silicone, you know there are contractions and this retina is already intrinsically contracted. So silicone for life, I think.
Yes, and we have some comments. Vitaliy, congratulations for excellent surgery. Is this patient immunocompetent now?
What? Sorry.
Is this patient immunocompetent
Competent.
now?
For now, he's in safe. His status is okay, but he have both eyes with a silicone.
Is he in hospital now?
No, he is at home.
Without immunosuppressive therapy?
He is on the local antibiotics, just eye drops, because we have a silicone and we have stopped the inflammation, as we can see. But he's on the silicone, and I think Lukan is right. He's on the silicone for much more years.
Thank you. We have one question in chat, and after that we will vote again. What your opinion about using intracameral antibiotics with intravitreal injection? Do you use it, Lukan?
Sorry,
do you use antibiotics into AC,
into AC?
Yes.
No, I think it's pointless, because the clearance time is like seconds.
Thank you. Hussain?
No, I don't use any intracameral antibiotics.
Thank you. Andrii?
I also don't use this way.
And Dr. Sallam? No.
Actually, I do not, and I think using it just for prophylaxis is probably like for medical litigations. In my view, I feel like the washout is very quickly and it doesn't help. So I do not use it. No.
If I may add, it can cause TAS syndrome, but nothing else. So, yeah.
Thank you. And please second poll. And this question: have your tactics changed after the speaker's discussion and presentation? Just say honestly.
It's more
yes or no? Was our discussion and presentation useful, fruitful, educative for you? Maybe for those of you who answered previously before. Now we have 95 participants. Thank you that you are with us. In Central Europe, it's night. Can you show us?
Can I have one question during the poll? Okay.
63% yes, and 37 no. Okay, maybe their opinion was the same, maybe not. Thank you.
Well, that's good. More than 60% changed their view. That's very good.
Can I have?
Yes, of course, yes.
Yeah. How often do you get referred case from anterior segment surgeons which already done a few intravitreal injections with no success, and then the case is referred to you? Do you face this scenario?
Seldom. For me, it's seldom. If we see these patients, it is not frequently. maybe there are a lot of patients who their result will be better and we don't see them. So we don't discuss it between maybe this is the reason. We don't know. But it's my my answer.
Mm-hmm. I mean, because there are a lot of anterior segment surgeons which are more confident in their abilities they should be, and they try to handle the endophthalmitis with something which is accessible to them, which are the intravitreal injections. But then when the things go wrong, they say, okay, go to the vitreous surgeon. This is my question. Do you face this scenario often or not?
No. Dr. Ahmed, how is in USA?
So what I got point from Lukan. So my preference is that if a anterior segment surgeons get endophthalmitis in his phaco surgery, I think he shouldn't inject. If he removes the patch and see the endophthalmitis, he should send it to the vitreoretinal surgeon, because whatever he does, it makes my job very difficult. Believe me. Even he is very much trained in intravitreal injections. Nowadays, many people are doing medical retina, the anterior segment surgeons. They are very much trained in injecting the anti-VEGFs. But that injecting the anti-VEGF and injecting the antibiotic in endophthalmitis eye is totally different. I would prefer not to inject, just rush the patient to the vitreoretinal surgeon, because this will make his life, his patient's life, eye and vitreoretinal surgeon's life very comfortable, believe me. Whenever I get a patient with injected intravitreal antibiotics, I get such like pale discs you saw in my cases.
Thank you.
So that's my humble opinion and a humble
Tatyana, is
suggestion.
there time for a quick comment on this one? Or?
Yes, of course.
Very quick. Okay. I think in my view, really, the main aim is to inject this patient within 1 hour of the diagnosis. If the surgeon is comfortable doing this, I would re-advise them to do this. Because by the time is the essence here, and intravitreal injection of antibiotic is just an intravitreal injection. And to be honest, vitreous step is not important, in my humble view, because we've seen from the endophthalmitis vitrectomy study that 7% only needed a re-injection. So the majority of patients will remit with one injection. The majority of patients will be treated by just empirical treatment without the guidance of vitreous step. So I think the main thing is just putting the antibiotic inside the eye, and really it needs to be done in a clinic. Already the eye is infected. That's my view.
Thank you. Yes, please, of course,
So if the anterior segment surgeon has injected the antibiotics and didn't take the vitreous tap or sample, then would you prefer this patient, if you get referred this patient, to take the sample of vitreous biopsy now after the antibiotics?
I would not, because the reason I mentioned really, most of these eyes remit with just one injection. I mean, the injections are very effective. Most of the eyes remit. It's very important also to, like for the audience to understand what we mean by like remit, because you don't imagine that everything is going to disappear. But you need to make a judgment based on the pain, vision, hypopyon, vitreous clarity, whether this patient is getting better or not getting better. And once this patient is getting a bit better, then this eye is sterile. And all what we need to do is lots and lots of steroids and wait. Then later on, we can deal with vitreous opacities if they persist. We can deal with epiretinal membrane.
Thank you. You can follow, please, Vitaliy, your second presentation, and we start our second part of conference about fungal endophthalmitis.
So the second case, the patient's 64 years old, had a COVID a month ago, and his visits on the right eye dramatically increased in 2 days and became praxillus certa. This is the pictures of the left eye. We can see here a white focus. And if we do the OCT, we see such picture. It's the left eye. The pictures of the right eye was too bad because we don't see too much the retina because of the inflammation. After we remove the vitreous core, this is a picture of the eye bottom that opens to us. As you can see, we removed the core. And I can show you right now. The central zone of the retina, large white focus, edema, and the macular hole. Also, you can see small focuses in the maculopapular zone, also, which also attracted attention. And it's not possible to remove the hair from the central zone, so I'll leave it. And but the small couplings along the vessels were easily to remove, as you can see. Right about the vessels. Then I tried to close up the macular hole in the standard way without using ACP, motivated by the fact that the blood plasma could contain maybe more pathogens that would change the inflammatory response. So I just closed the macular hole with the membrane. It was decision of the minute because it was only seen on the operation. That is why the silicone oil tamponade. That's because of the macular hole and the inflammation. So we plan to remove silicone oil about in 2 weeks and maybe replace it with the gas tamponade or something. Sorry. That's a picture on the first day after the operation. You can see that the macular hole is done with the membrane and silicone oil edema. And what we have on the first day, we have a hand movement against Praxis lucerta. And we have such a conclusion after crops. It was Candida albicans. Maybe it's the COVID response, maybe on both eyes. And this is not first one patient with the COVID, after the COVID, that have both eye uveitis. Maybe it was exactly 9 or 10 patients like him. But not always it was fundus, but both eyes uveitis after the COVID, I think it's some kind of statistics already. 10 patients with both eyes. Thank you.
Thank you so much, Vitaliy. Again, great case and interesting because we are living in this not easy time. So we will have also, I think, such patients with such problem. Do you have some comments, colleagues?
It's a great case. Well done.
We will continue our
Can I
topic
have a
about
question?
fungal. Yeah, of course.
Maybe what kind of surgical tactics do you prefer in that case about macular hole? Maybe CP or PRP, or just like that, or do nothing? I don't know. How do you think?
Okay, PRP means plated rich plasma. Please, Dr. Ruban, what's your way of treatment?
First of all, it's a great case. It's fantastic. It's not so usual as macular surgery to see what you saw. I think it's a traditional classic approach is maybe not so useful. I mean, classical peeling and closing the hole. Maybe I use LM flap. Maybe not free flap, but LM flap. Maybe more wider to close this so changeable edge of hole. But I never seen this guy. I don't know.
Yes.
Please, Dr. Lukan.
Fantastic surgery. The way I see it is the most straightforward way to handle it with the ILM flap, because such a hole, it's rigid and it will not close with drainage or massage. So we need to plug it with something. Next thing is to do a retinal autograft. In endophthalmitis eye, it's overkill. So I think the flap was really a good solution.
For me as well.
Thank you.
Yes, please, Ahmed. What's your approach?
Yeah, I think I would have done the same. It's beautiful surgery and a difficult case. You've done so well, Vitaliy.
Thank you.
Thank you, Hussain.
Very beautiful surgery, Vitaliy, and good time decision. I liked your decision. The only thing is, yes, in this case, inverted flap or temporal flap would help more rather than for traditional ILM where you would have a much more better results, because you are giving a scaffold for this large break, I mean macular hole, and it has more chances of closure, whether it will be type 1 closure or whether type 2, but it will be far better than remain the open macular hole. So very nice case and rare case. Well done. Thank you.
Thank you.
Thank you. Our next speaker, please, Lukan. The floor is yours, please.
Do you see my presentation?
Yes.
Yes, I will also talk about fungal endophthalmitis, and I think that the timing is crucial, and also the time when the patient is coming to us can lead us to the initial decision: is this a very bad bacteria, or this can be a fungus? Because normally the fungal endophthalmitis are not so devastating and not so dangerous as a picture. There is no ecchymosa of the conjunctiva. The eye is not so red, bloody red as classic endophthalmitis. So we need to start with the history of the patient to sort of get the idea what we are searching for here. So here is a case of post-cataract endophthalmitis, which was treated like 20 days with antibiotics and anti-inflammatory, and the case was referred to us. So a little bit on my technique. I always use non-valve trocars in endophthalmitis surgery, of course, single-use ones. And here you will see me using 2 syringes to take a tap, because we normally use Bactec blood media for aerobes and anaerobes. And also we use a cotton swab. Why? Because when we send for culturing, we need to explicitly write that they need to search for fungus, because the media is completely different than the media for regular bacteria. So I sort of disagree with Ahmed for the Vitro tap under air, because if you, for example, have anaerobic bacteria, probably you can compromise the sample. Here I'm removing the already implanted IOL along with the capsule complex, because you see the capsule complex is already well infused with the presumed fungal material. And why we thought that this is a fungus, because you see the eye, the content of anterior chamber is not always a hypopyon. Actually, the fungal endophthalmitis, which I saw, all the material is located on the angle and not on the lower side, but in the periphery on 12 o'clock. Here, what we see in the vitreous, we see milky-like appearance of the vitreous and posterior hyaloid. So we see we have a fundus with engaged vessels. You see the whitish material around the arcades and around the vessels. So I normally here you see there is already an induced PVD, and normally I try to clean as much as I can. What I do, here I use fluconazole in the infusion. Why in the infusion? Because I will definitely end up with silicone tamponade, and that is the way I get my antibiotic or antifungal to the retina before I implant the silicone oil. Now you see the periphery. I try to clean as much as I can without pulling, because the retina, as we know, is really fragile, and we can create a break, or a break can happen later, even under the silicone tamponade. So here you see the material. I try to remove every white dot and flake or whatever it is. And normally you see they are really well attached to the ciliary body. And yeah, with soft vacuum, one can carefully remove them from the retina, but with Charles cannula, they can be blown away and safely removed later, actually. You see the optic nerve, it's a little bit reddish and inflamed, and the white dots actually the same as Vitaliy case presented before me. Yeah. Now silicone oil tamponade, as I said, it will give me a confidence and room or window for action until I have my antibiogram done, and to settle the retina and to see what is the functional potential of this eye after cleaning the endophthalmitis material inside. And actually, the early vitrectomy versus intravitreal injection, it's sort of confusing for me, because from the general surgery, we know that we need to evacuate the inflammatory material in order to treat the inflammation, right? When we do an intravitreal injection, we just I don't know what we do, because we don't remove any purulent material from there. So this is the eye 1 week post-operative. and the patient is still on fluconazole oral administration. What is interesting in this case, it came up Candida guabrata as a bacteria. So here is 1 month post-operative with silicone. Fluconazole was stopped 5 days ago, and we already have a collection. What we understood by that is that the place of residence of the spores is probably the angle. And the next thing that we understood during our case was that the fluconazole is active only on the active forms, but not on the spores. And that explained why after we discontinued the fluconazole, there was a recurrence of the situation. Then we again gave fluconazole and the situation got better, but you see again, this is the image after the second fluconazole treatment. So we decided that we will remove the silicone, but this time we will use voriconazole as an agent during the surgery in the infusion. Also, the patient would receive 200 milligrams intravenously, and then there will be an oral therapy with voriconazole. Why? Because the voriconazole is active against spores and active forms of the fungus. Now, silicone oil removal here. The eye looks more or less okay, but still we saw some activity as hemorrhages. The interesting thing is that the iris is so rigid. I tried to pull it here, but without any success. This was something new for me. And it was, you see the membranes, and this is the proof that probably the spores are residing in the angle. Then a week after the silicone oil removal, and when the gas disappeared, the patient returned with really nasty retinal detachment. So you will see now what is the picture. Now this is the picture, really nasty. We have a membranes, we have a peripheral pooling. So the question, if we need to clean the periphery or to remove completely the hyaloid, gets his answer here. We need to, at least in my opinion, we need to clean as much as we can on the first surgery, because this is what we face later. Here you see a really taut membrane, which is around the optic nerve, and it's pulling the retina. Fortunately, it was more or less easy to be removed from posterior pole, but then in the periphery, there were really well attached PVR membranes or inflammatory ones. You see how firm is the attachment here. And the hemorrhages around the retina, for me at least, are indicative for ongoing inflammation, albeit the voriconazole treatment. So the fungal endophthalmitis is not a one surgery solution, at least in my hands. Now here, after 2 hours, I performed 360 retinotomy, and I will finish the case with silicone oil tamponade. So I will rush a little bit here. And this is how we end up the case. For me, what is important is always to suture the sclerotomies when we have endophthalmitis, because there are entry wounds still. So what we do as a culturing media, we use Bactec plus aerobic and anaerobic and cotton swab. This is our method of treatment with fluconazole, or better, voriconazole. Antifungal agent into irrigation solution is 0.1 milligram per 1 milliliter. And here is one case which was managed by a colleague of mine, Dr. Ozana Muraru. The same picture, and was managed again with fluconazole and later with voriconazole. So you can see on the left side how it presented, and you see on the right side 2 weeks later how the eye looks like. And something a little bit more scary, it is again presumed fungal endophthalmitis, and you see how it is not a hypopyon but on the upper part, like inverted hypopyon. And this is the surgery. You see the membranes. So not every fungal endophthalmitis is so good or so mild as presentation. Here I will fast forward a little bit. We need to clean the membranes here. You see the yellowish liquid which is going out. And then the posterior segment here will be really scary, actually. So the visualization is actually really tough here. And this eye, in my opinion, is more or less unsalvageable. Also on top of that, there are choroidal bleedings here, something that you need to have in mind when the patient is in anticoagulant therapy. And if you give fluconazole, it increases the half time of life of the syndrome, for example. So you can have bleedings related to the dose which need to be reduced when you give fluconazole or voriconazole. So it's a good thing to know. And you see the yellowish matter, which is normally residing on the bursa premacularis and prepapillaris, which is supposedly the way that the infection got to the posterior segment from the anterior one through the vanished Cloquet canal, probably. So here it is. I just showing this situation to remind that the fungal endophthalmitis can be devastating also. So and now here I will do a fluid air exchange, and I will put silicone. And that's it. Thank you.
Thank you so much. Challenging, fantastic cases. Really nightmare. Your second case and first the same. What about first patient? Is he still in with silicone tamponade?
Yes, she is still with silicone tamponade because the eye developed vascular incident under this tamponade, and it was related with her coagulation status. So the eye now is only with temporal light perception. And I presume that the cyclitic membranes around the ciliary body has made it to stop working. And if I remove the silicone, it will go to phthisis. So after 3 or 4 surgeries, unfortunately, this eye will maintain only the shape, not the function.
Yeah, thank you. And in your next case, what about choroidal detachment now? Because I saw there was choroidal bubble, no?
Yes, but this patient was with these are choroidal detachment related to the polypoidal choroidal vasculopathy. So this is eye without good future also.
Yeah, of course.
So it's like light perception, but nothing else. Because you saw the retina is.
Yes. What about another eye?
What about?
Another eye, a second eye. Is it okay, or with also with
on the first
some
patient?
Inflammation? Yes.
No. In both cases, it was post-cataract surgery. So
Okay.
it was not endogenous.
Endogenous, yeah, okay.
Yeah, so the other eyes hopefully are better. They are better now, but hopefully they will be better in the same status in the future also.
Now I understand your question about treatment of cataract surgeons. Thank you. Thank you so much. Do you have some comments or questions?
Can I?
Yes, please.
I think that as we can see, that the fundus and endophthalmitis are pretty bad situation for the eyes. Maybe it's like Streptococcus aureus, Staphylococcus aureus, or maybe Pseudomonas aeruginosa. It's a really heavy eyes after the fungus. We have in our clinic a little bit of cases with the fundus. There was exactly like Lukan showed in the second case with the choroidal detachment, and the patient have no vasculitis, just only fungus and choroidal detachment, retinal detachment, and there is no way to escape, because I think that we extract the silicone oil, give it to the laboratory, and we found that the fungus are rising in the silicone oil. So the silicone oil was not a problem for the fungus. And that's and even if it on the both eyes, it's pretty bad. To have such cases, it's really bad.
Thank you for your comment. Hussain, yes, please.
Yes, my comment is regarding the first case of Lukan. At what time you removed the silicone oil in your first case?
Around between the third or fourth month, because I got 2 sessions with fluconazole, which were 20 days. So probably around the 3rd month, because I saw that when we stopped the fluconazole, a week later, the fungus started to grow again in the anterior chamber. So we decided to look for additional drug to use, and we found voriconazole as an option. Actually, after our second vitrectomy, there was no fungus growing anymore, but there was already the retinal detachment and the iris rigidity.
Actually, the issue is, did you do the encircling laser or barrage laser after the first vitrectomy in these cases?
No.
Or after the oil in few days post-operatively?
No, I haven't done any laser because and in the first surgery, I haven't found or created any hole. And retina.
I'm asking about the encircling laser, 360-degree encircling laser.
No, I avoid it in retinal detachment because the retina is so fragile and the iatrogenic breaks can occur from the laser.
But I think that in these eyes of endophthalmitis, if we are not able to shave the vitreous base, there's a lot of debris on the anterior retina. And what I feel difficulty that when you remove the oil, this debris may create contractions and PVR retina get detached. So that's why I prefer 2 or 3 weeks later after the surgery, in the silicone oil, you can do the easily organ laser 360-degree barrage relatively posteriorly. That helps in my understanding for the detachment of the retina when you remove the silicone oil in post-endophthalmitis vitrectomatized eye. I think it may help a little bit way, but not every time.
There is a logic, I agree, but as you saw later, inflammatory membranes were the source of the detachment, and one of them was originated from the optic nerve. So probably it was hyoid schisis on the first case, something like that.
Yes.
Mm-hmm.
Thank you.
Thank you. We continue our topic about fungal endophthalmitis. Please, Ahmed, can you share your experience
Yes, sorry, I
with
was
us?
trying to look at the order of the presentation. Thank you. So, okay, can I, sorry. Let me share best the screen. I have a point that in reply to the question that Lukan asked about there is pus in the eye in endophthalmitis, why don't we drain it? Or, I mean, it's like logic to be able to drain it, right? I just want to show you something that I all thought about. Can you see my screen?
Yes, clearly.
So that's one of the criticisms to the endophthalmitis vitrectomy study is with the general surgeon mentality, any pus has to be drained, right? This is an abscess, you have to drain it. But that's not true in that situation. I'll tell you why. And even general surgeons go to say that, you know, this is the ocean, right? And this is an antibiotic. This kid will never pollute the ocean, right? So the same thing the antibiotic does to the pus, which is really true, but not in endophthalmitis, because again, we're talking about 50 to 200 times MIC. And that's really the doses used in encephalitis and meningitis. So we don't, in encephalitis and meningitis, we don't drain the brain. And also these super MIC doses, they penetrate into biofilm. That's why in pseudophakic endophthalmitis, in post-cataract endophthalmitis, we don't remove the lens, because although the organisms make biofilm, the antibiotic at that high dose penetrates into the biofilm. So that's really my thinking about, you know, why we're not following the general surgeon mentality with pus drainage. But I think it's a point that we can argue about it a lot. But I just remembered my slide and wanted to show you. Okay, so Candida Endothermitis. Can you see my presentation?
Yes.
Okay, I'll start just the other way to sum up really the treatment, and I should be in time. This is a macro pathology section from when I was a fellow at Morphos with Professor Lightman. That's one of her patients who unfortunately died, and then we got the section. And really it shows here something very nice to, especially for the audience, to notice that the organism comes from the choroid in. And that's very important, because if you find this patient where they have non-elevated chorioretinal lesions, you can just treat them with systemic treatment. That's more than enough. But if they bud inside the eye, then now the lesion has penetrated inside the blood retinal barrier, and systemic is not enough. And that's where you need intravitreal antibiotics. It's just something nice to remember. So how do we treat these patients? We use systemic treatment. One point Lukan mentioned on very nicely is that fluconazole is actually not very effective in Candida glabrata and Candida krusei as well as filamentous antifungal. So in these cases, it's best to use voriconazole. Fluconazole is cheaper, more available, and less liver toxic, and has less drug interactions compared to voriconazole. But Candida krusei or glabrata or filamentous definitely use fluconazole. Okay, what's the role and what intravitreal amphotericin B is fine, but voriconazole might be better, safer, less focal necrosis, but again, the problem is more expensive. What's the indications of vitrectomy? We looked into that in one study, and there were several studies. Most important of them is Bahira study, where we found actually it does not change the visual acuity. So it's good for management of complications, but should we do vitrectomy for all patients to improve the acuity? Both studies found actually it does not improve the final visual acuity. We found that it decreases the need for later on vitrectomy for vitreous opacities, as you would expect. There was also decreased risk of retinal detachment, but it did not change the visual outcome. So where do I use it? I'll show you when I use it. I use it mainly for the management of complications, but initially we treat patients with injections and systemic treatment. So this is a case where a patient presented with unclear history of decreased vision, gradual further probing and probing and probing. The patient was intravitreous drug use, and he had these lesions here. And then this patient did so well with intravitreal injections and systemic that the lesions healed up. And now the main problem was the lesion distorting the macula and the vitreous opacity. And that's where we took the patient to the operating room. And that's the appearance here. So cutting down the synecdoche. And then clearing the vitreous opacity. The view was not very good from the cataract. Sorry, here, this is vitreous biopsy under air. Because at that time, we did a vitreous step, and that came negative, and the diagnosis was all presumed. So we did a vitreous biopsy to try to see if we can get anything out from that. And that's vitreous biopsy under air, now switching to fluid, and this is the appearance here. And that's actually a lesion on the nerve and the macula. That's not the disc there. And you can see the budding lesions, which is very suggestive of Candida, but at that time, the diagnosis was just presumed. So I took the lens out. And this young patient, 40 something, so very easy to bring the lens in the antechamber and just remove it. And then I did the vitrectomy, and the patient had just some attachment of the hyaloid, was not very adherent. And this is the Candida lesion over the nerve and the macula. And I got so excited, and I really wanted to get this lesion out and send it for pathology. So as diabetics, you can peel over the disc. You don't peel over the macula. So here, peel till the disc, and then here it was adherent. So you need to stop, otherwise you'll cut the retina. And then bimanual dissection. And then the fungal ball was released, or the presumed fungal ball till that time was released. Then I did a posterior capsulorhexis. And now the lesion is outside the eye, in the antechamber first, then bringing outside the eye. Thank you, Linda. Then actually we did histopathology. You can see hematoxin, and you see inflammation, necrosis. And then with histopathology, we could find Candida lesion with the GMS stain. So that was an interesting case. The patient did so well, but he refused to have a secondary IOL, and he did with contact lens, 20/40 vision with contact lens. So this patient did so well. Then another case here where, again, that patient was referred me because of a tumor. Then the thought was this toxoplasma or a TB granuloma. And that's a pattern, again, with fungal when they start to heal. And that's before treatment, they go into a granuloma, and that's why you can get tractional detachment. And again, further probing, the patient did intravenous drug use, so that was a presumed fungal infection. Treated with systemic and intravitreal, and the lesion healed. She ended up with epiretinal membrane and some vitreous opacities, and we went for surgery. And in this case, sorry, her video has a problem exporting. And that's the lesion here, which really completely healed with vitreous opacities. And this is the appearance here. And ERM, ICG, and I took her lens out, and the view was not very good, so open the capsule. And then you can see the ERM, so ERM peel. And usually I would stop like this. I don't like peeling the ILM, but you can see there are still folds there. So I thought in this case, okay, and part of it was already removed with the ERM. So I stained again, I peeled the ILM. Otherwise, I'm usually conservative, and I don't really like peeling the ILM in diabetic or uveitic patients. So I peeled the rest of the ILM. The question is, would you do something for this lesion and try to remove it, or leave alone? And in this case, I would leave alone. It's very difficult to remove. You'll end up with breaks, and there's no really point removing it, in my view. So leave alone, and I left the eye balance BSS filled, and we just closed the eye. And yeah, that's it. Thank you so much.
Great, thank you so much. Fantastic cases, great presentation, as always. Was this lesion with some traction around it in last case?
Where was, sorry, pardon? There was a detachment around it?
Not detachment, traction. Traction or fold around it.
There was some traction around the lesion, but really, I thought it's best to leave alone. I tried to remove over it, and I'll end up with a break. The retina was thin, the lesion was healed, and mainly subretinal, and was really out of the macula. So I just peeled around the macula, and I relieved by peeling the ILM, and I thought I'll leave like this. But yeah, there was actually also an exudative component to start with that settled but left traction around it.
Thank you. Yes. Thank you. Do you have some? Yeah, please, Lukan.
I want to comment on the histopathological specimen that you showed. It was really nice. That explained my last case, which I thought it's some pathology in the choroid. Probably it was just the fungal eruption into the eye. So thank you for sharing that. Yeah. Really good point.
Yes, and I've seen that they go more around the nerve. It seems like they go through the cavities there. And interestingly, I mean, as you would expect, the vitreous biopsy did not show anything because she was on treatment, I would presume. But histopathology showed the fungal.
Another thing that we need to mention is that a lot of studies show that at least for the voriconazole, it doesn't matter if you give it systemically or it is into the vitreous. The concentration in the vitreous is enough. So the penetration into the ocular tissues is somehow really good.
Yeah, and fluconazole is like this. The bioavailability of fluconazole is also fantastic. But I think the thinking is that if the lesion is inside the eye, you may be better reused as adjuvant treatment. But I think your point, yes, is very clear. The main treatment is systemic.
Mm-hmm. Mm-hmm.
Can I have a question, please?
Of course.
What do you think about leaving fluconazole in the anterior chamber? I don't know, for just leave it.
Yeah, so there was only, I did a review article not so long, and there was only one paper read that used fluconazole inside the vitreous, and there were even thoughts of fluconazole implants, but that did not kick in very well. And I think there might be a toxicity issue. I wasn't clear why fluconazole was not used, but I would use just intravitreal voriconazole or amphotericin B. I don't know about the safety, but it was not really extensively used at all. And I think the antechamber medicine, as Lukan mentioned, the problem is the wash is so quick.
And for the fluconazole, the thing that we noted is that spores are not treated at all with the fluconazole. And we know that the Candida have a 48-hour cycle of renewal. So after every 48 hours, you will still have spores that are not active, so you don't know where they will activate. And voriconazole is my answer at the moment. There is a new drug coming along, but I don't remember the name, better than the voriconazole, and again from Pfizer. No commercially related with Pfizer, of course.
In many of the Pfizer's medicines start with a V, right?
Vifent, yeah, sure. This is the voriconazole.
Thank you. Let me show you my cases. My topic is about endophthalmitis following intravitreal injection of anti-VEGF agents. Can you see my presentation?
Yes.
Okay. First of all, endophthalmitis following anti-VEGF agents are extremely rare, and on average are 0.019 to 0.9%. And predominant positive organism is Streptococcus species. Here are the known recommendations how to avoid or reduce the risk of post-injection endophthalmitis, and using the povidone iodine prior to surgery played a major role. Also, following by eyelid retraction and speculum, avoidance of needle contact with eyelid margins and eyelashes, and avoidance of routine topical antibiotics, and respiratory droplet reduction due to streptococcus. And we need to wear face mask and not talking, but it is a controversial point. So let me show my case. This is the patient who came on her 6th day after aflibercept injection. We left the lens and put as a sample from anterior chamber, but we don't have any culture growing. It was sterile pus. You can see vitreous opacity and neuroretinitis with intraretinal hemorrhages, suspension, white suspension. I collected with basic aspiration. It's ischemia. It is not a pus. And after that, I continue as much as possible peripheral vitrectomy and finish by silicone oil. Honestly, after this meeting, next time I would be finished with air, of course. But I decided to do it because we did not put any antibiotics administration, and after 2 months we removed silicone oil plus phaco, And her vision acuity is 0.3. This not that good result due to geographical atrophy. My next, my questions are: would you do intravitreal antibiotics and wait 24 hours, not do vitrectomy? And would you finish with air tamponade? Maybe we will discuss just now. Who would put air, just air? You can raise your hand. Yeah. Oh, Lukan and Hussain.
I can't hear you. Can you please repeat the question?
My question is: would you finish with air? This
No.
this question. Silicone oil.
Yes.
But I changed my opinion. Okay.
You can change your opinion on your case, but the issue is not the tamponade. The issue is how you want to salvage the eye. Would you be much confident to salvage this eye with your gas or air or BSS? That makes sense, because it's not the 1 day or 1 week you are salvaging the VN. It's for the whole life, because you don't have a second chance or third chance. Look and show the first case. See, if the situation was much better after the first surgery, but as you go on, situation get more worse. So the one surgery that ends up good in endophthalmitis eye is the necessity, not the different parameters of playing with the endotamponade. What's wrong? I just can't understand what's wrong with the silicone oil tamponade. What's wrong? It's just 5 minutes to remove it. It hardly takes
second
5
surgery. It can cause
second surgery.
some proliferative.
It hardly takes 10 minutes to remove the full surgery for silicone oil removal. You put the speculum, you inject, and it hardly takes 5 minutes to remove the 1000 centistroke silicone oil. The time, how much you spend for an intravitreal anti-VEGF, almost the same side, little bit more. It's not that second surgery, but the thing is that if you get redetachment of this patient after 2 weeks, what would you have an answer for this patient? And this redetachment, it is always with much PVR, with the anterior PVR, and anterior PVR is always difficult to peel. And for the anterior PVR, you have to do retinectomy, and a retinectomy always induce the PVR. So where we are going to end this case then? That's my only concern for these things.
We saw fantastic and good results.
I would prefer BSS. I would prefer air. I would prefer gas. That's beautiful things looks like. But you do the 500 cases or 300 cases of endophthalmitis and leave those eyes on BSS, and you will see how much patients waiting for you in your clinic with these thiacical eyes.
Okay. You have a really difficult life. Thank you.
Yeah.
Thank you. Who would wait and don't do vitrectomy? Who would tap plus antibiotics without vitrectomy? Please unmute.
Well, give injection. What's the question? Give injections and wait?
Yes.
Yeah, I would do that. And just quickly, Khaqan, I mean, I think you're talking about the bacteriostatic effect of silicone oil. But again, I think it's, if you balance this with the antibiotics, you know, it's a big difference. But, you know, different ways of doing things. And that's why this webinar is so important. But I would definitely wait and give injections first.
Yeah, it's interesting. Yes, please. Thanks.
Yes, go.
Yeah. Lukan, what comments?
Two comments. First, the silicone oil is not only for bacteriostatic effect, and I agree with Dr. Hussain that it gives a time, and the retina is more supported and relaxed with silicone oil during the period of the recovery. Because what we're going to do after 2 weeks when we have a total PVR, right? And the second one, I wouldn't do any injection. I do immediate vitrectomy. I'm a private practice and I can open my clinic whenever I can. If I have endophthalmitis, I do it as soon as possible. Vitrectomy, early one, not anterior chamber lavage, etc. Full vitrectomy.
Thank you. Yes, please.
Tatyana, we are talking about post-intravitreal injection
Yes.
endophthalmitis, yes?
Yes.
Yes, obviously. So what my personal observation is that the endophthalmitis in these cases is not very much severe. We don't see such like endophthalmitis as we see in post-cataract surgery. This endophthalmitis is a bit like as you see in vitrectomatized eyes after macular hole or epiretinal membrane peel. That eyes has BSS. This is not severe. But again, if we get such like endophthalmitis, if it is early and it's acute and it's aggressive, I will go for the vitrectomy only, no intravitreal injections.
Thank you. Thank you.
In the case that you shown, how many days after you got this endophthalmitis? 6 days after. So it's mild, it's not very severe. So vitrectomy could heal it up. And if it doesn't have any retinal ischemia, the patient will get 100% vision. I think it's no doubt there.
But her vision acuity was like perception.
Because in your case, it was severe retinal ischemia there.
Yes,
Retina
yes.
was very much ischemic, as you see during vitrectomy. It's very much ischemic. It's due to the toxicity of the bacteria or the other factors that make retina very ischemic. It's not because of the virulence. It's not because of the endogenicity. So it's more about the ischemia that make that vision very worse in your case.
Thank you. I continue. My next topic about chronic delay onset endophthalmitis, and there are not so many publications about this topic, and I can find only one about delay onset Streptococcus intermediate endophthalmitis following anti-VEGF agent. So the variety of organisms have been implicated in chronic post-operative endophthalmitis with Propionibacterium species, followed by coagulase negative staph and fungus. But it's about post-operative, not post-anti-VEGF. Our case, about 80-year-old female, she has bilateral neovascular AMD, and we put her 2 injections anti-VEGF agent on February and on March. After that, she lived not in Moscow, in another city, and due to COVID, she could not come to us for continuing her therapy. And she took the medicine in local clinic, and her last injection was in November 2020. At that time, she felt that her visual acuity decreased in her left eye. The presumptive diagnosis in this clinic was vitreous hemorrhage, and she took intravenous antibiotic therapy during 10 days. She came to us, was able to arrive only in January this year with this picture, this hand picture. And so she was 80 years old with cataract. We changed the lens, put IOL, and started the vitrectomy. You can see vitreous opacity, whitish port in vitreous cavity. I did the vitrectomy. saw some hemorrhage intraretinal, white round spots, as Vitaliy showed us, and roof membrane epiretinal with strong fixation. I don't know, maybe it's fungal, I don't know. With passive aspiration, we can do it easily. I separated this, I divided it between macula and optic disc and removed the forceps. It was not so fixed as I thought. And say it again, as Ahmed shown. Did posterior capsule, capsulorhexis, just for some improvement of visualization, this patient, and put a suture, put injection with antibiotic, with steroid. This is the picture of this patient, and there were no inflammation after it, but we had some fibrin tissue in anterior chamber, but it was resolved. Thank you for your attention. Do you have some question or comments?
Tatyana, great case. I have a question. It looks, when you were doing the vitrectomy, it looked like fungal to me.
Yes, your last case.
The last case, was it, it never grew fungal, like? It did not.
We don't know. We don't have some positive culture.
Did it grow?
No.
Fungus or?
No growing.
Right.
Yes, no.
And was the patient given antifungal? Was the patient given antifungal or?
No, nothing. And she did not receive previously some antibiotic therapy, or she was not immunocompromised. No.
Right. Yeah, it looked very much fungal, but it's great that she did well.
Yes. Just vitrectomy and nothing else.
Right.
Yes.
Dear Tatyana, in cases with post-injection endophthalmitis, when patient need additional treatment, are you planning to inject, re-inject anti-VEGF?
Anti-VEGF.
Yeah, after endophthalmitis.
I almost never met reactivation of neovascular membrane after vitrectomy for these patients, but I have one who had reactivation 1 year after vitrectomy, and I did him 2 injections of aflibercept for his myopic neovascularization, and fortunately there were no inflammation after that. The explanation is that we eliminate these agents and VEGF agents from vitreous cavity. I read it in works. Thank you. Yes, please, Lukan.
I want to comment on how we actually decide if we are in a hurry or we can wait. Do you have any additional signs, not only the biomicroscopy, I want to touch a little bit on the B scan, because for me the B scan is something which is really important and is sort of tipping point when I see certain things on the B scan which will make me to go in emergency vitrectomy or to decide to wait a little bit. Can I share my screen for a moment?
Yes, please, of course.
Yeah. Do you see this B scan?
Yes.
So for me, when I see hyperreflective PVD already present and edematous retina, this is a clear sign that this is a severe endophthalmitis with retinal engagement. So I think we should mention that the B scan could be one of the leading signs or examinations to tip the scales in direction of the vitrectomy or wait and do, for example, intravitreal injection. Do you have any additional signs, for example, in the B scan or something else?
Yes. Vitaliy.
Yes, of course, the B scan is pretty much important when we decide to vitrectomy or not. But we have, I don't know, do we have flicker fusion critical frequency? You know, that's
No.
that's kind of examination. It's like so. Tatyana smiles. She knows about it. We use it in Russia. It's a very, very old method, but it shows us if the progression of endophthalmitis are really heavy and speedy. We can check that frequency, maybe just 1 hour, and if we saw that the frequency is delay slow, then we go into the direct.
Sorry to interrupt. You mean like retinogram?
Not exactly. It's the frequency of the optic nerve.
But it's still electrical potential, right?
This is I just know not the electrical potential. Maybe it's like the patient reacts to the flicker of the lamp. It's just a reaction of the patient. It's not an electrical potential. And if we saw that the reaction is too low, we're going to the vitrectomy, and we can decide it in 1 hour.
So it's sort of functional testing, right?
Yes, yes.
Thank you. Andrii, can I ask you to show one newest?
It's, if it's possible, I would like to share my ecran. It's a few words about how to prevent, if it's possible, or a little bit decrease the rate of endophthalmitis as a prophylactic tools. It's material by my friend and my colleagues, Lubomir Litvinchuk. He invited some new needle for intravitreal drugs delivery, which has some advantages. It has a closed outer orifice and side port for drug delivery. And this needle injects less extra and intracellular bacteria and biological active substance and proteins, which can reduce the risk of septic or even septic inflammation, because we don't input inside eye some particle of conjunctiva and another type of cells. For me, it's very interesting and very useful. It looks like stiletto. It's conventional needle. And finish. Thank you.
Great. Thank you, and many thanks to Dr. Litvinchuk that for this opportunity to see this device. And it's a pleasure that you show it in our meetings. Thank you. It's an opportunity for our participants also. Does you have some publication, or you show us this, this?
Yeah, it was published, in Clinical Ophthalmology, as I mentioned correctly.
Thank you. Do you have some comments?
If I may add, the needle is simply genius design, and it can be used also for a suprachoroidal drug delivery, but with a little bit changing of the design. But it's really clever one. Congratulations.
Thank you. Thank you so much. And I don't have any questions. So I think today's meeting was very educative, fruitful for everybody, and tomorrow we will treat our patients better than today. And our participants, almost 100 of them, were with us during more than 2 hours. My deepest gratitude to you, our fantastic team of panelists, to our participants, all participants, because they are mandatory part of this meeting, and we welcome your feedback, of course. I also would like to thank Dark Company for their technical support and ideas and help how to improve this conference. And I very much hope that every one of you enjoyed these hours, this webinar. So as in a song, Andrea Bocelli, it's time to say goodbye. So have a good evening and day, Ahmed. I'm going to operating room. We can't hear you.
Yes, I really enjoyed the meeting. I got a bit under pressure, when at the end, because I had to go, but it's fine. I'm very happy, and it's a very nice meeting. Thank you so much.
Thank you. Thank you. Have a good day.
Thank you.
Thank you so much.
Thank you.
Bye. All the best.
We'll see. Thanks.
And thank you to everyone. Thank you.
Take care.
Thank you.
Bye-bye. Thank you.
Bye.